and the large group that is joining us remotely. I'm David Dubois. I'm the Associate Dean for Research here in the UIC School of Public Health. And it's my great pleasure to welcome you to the academic year 21-22 Distinguished Lecture. And before we turn to our distinguished guest, Dr. Freudenberg, I do have a couple words from our sponsor. So the UIC School of Public Health is Illinois' only fully accredited School of Public Health. We recently celebrated our 50th anniversary. We have divisions of health policy and administration, environmental and occupational health sciences, epidemiology and biostatistics, community health sciences, a number of special programs and institutes such as the Institute for Health Research and Policy, which is multidisciplinary and serves the whole campus. And we offer master's doctoral programs in all those areas, as well as an undergraduate program and a DRPH program. Our enrollment rose 15% this last year, so we're really excited about helping to educate the next generation of public health leaders. The focus of the school is very much on health justice for people in Chicago, as well as communities around the globe. We have a strong global health program. During the pandemic, SPH faculty worked in advisory capacity with the Illinois Department of Public Health, Cook County Department of Public Health, and a co-leader of the City of Chicago's contact tracing initiative, and as well as the campus initiative here at UIC. And latest initiatives in the pandemic are focused on also now on developing citizen skills in public health. So if you get lemonade, get lemons, make lemonade, right? So really a great opportunity to create pathways into public health for groups that may not have had those previously. This is supported by a robust portfolio of external funding, grants, contracts, $39 million in the last fiscal year, and between 5 and 7 million of that COVID-related funding has been received. So turning to Dr. Freudenberg, it's really, as I say, a distinct honor to be able to have him here and be able to introduce him. He is braided throughout his decades-long career. His wife says over 100 years, but I'm going to think it's probably a little shorter than that, although the volume of his work would suggest otherwise. Activism and scholarship, and so really fits in so nicely with the mission of our school. He is a distinguished professor of public health at City University of New York, CUNY School of Public Health. He's also the director of the CUNY Urban Food Policy Institute, which he founded. And he also founded and directed the Healthy CUNY, a university-wide initiative to improve the health of CUNY's over 250,000 students. So that's a true population level effort, right? His research interests include urban food policy, corporate practices in health, social determinants of health inequalities, urban health, and interactions between public policies and community interventions. He's published prolifically, academic journals, but also books, Not in Our Backyard, Legal, but Lethal, if I didn't get that backwards. And his most recent book, which will be the basis for his talk today, At What Cost? Modern Capitalism and the Future of Health. And the title of his talk, which I think you can see, no, not yet, but you will probably, but I'll say it in any event, 21st Century Capitalism and the Future of Public Health in the 2020s. So without further ado, let's all welcome Dr. Freudenberg for his talk.
Thank you, David. It's really good afternoon, or good morning to those who are in other time zones on Zoom. It's such a pleasure to be here with you today. This is my first public talk since March 2020, and I can't imagine a better place to do this than in Chicago and here at your School of Public Health. It's also the first talk I've given since March 2020 where I'm wearing long pants. You can see this both on Zoom and in person, and that's also a new experience since the pandemic. The last few years have been a stellar time for apocalypse watchers. Together, we've witnessed the unfolding of the COVID-19 pandemic, the eruption of disasters related to climate change, forest fires, tropical storms, droughts, flooding, and the human cost of each. We've also continued to observe the slower motion apocalypses that started in previous decades, the rising burden of chronic diseases, the so-called deaths of despair, including the more than 840,000 overdose deaths since 1999, the human suffering imposed by increasing mental health problems, including depression and anxiety, and the growing toll of workplace injuries and deaths. Truly, it's been an amazing era for those of us charged with studying and chronicling public health disasters. In my talk today, I want to take a step back from the specific disasters that have occupied so much time and attention of those in the room and those of us in public health in the last few years, and ask some more basic questions. For the last 50 years, I've been a public health professional practicing in New York City, watching and responding to the unfolding of the financial crisis in the mid-70s, the devastating impact on population well-being and inequality, the HIV, homicide, and substance abuse epidemics, and some of the innovative civil society and government public health responses to those crises. I've also been a public health researcher, studying the history of public health over the last couple hundred years and evaluating the impact of many health programs and policies launched in New York City in recent decades. And from before my public health career started, I've been an activist, participating in and observing and writing about the anti-war, environmental justice, civil rights, women's, labor, and food movements. So a little bit for SDS, Peter. And from those vantage points, as a public health practitioner, researcher, and activist, I have never seen a time where the threats to human and planetary well-being have been greater. Nor have I seen a time where the gap between what we could achieve with human knowledge, wealth, and science and technology and what we are actually experiencing has been greater. And my aspirations for today's talk and for the book I wrote, At What Cost? Modern Capitalism and the Future of Health, is to explore that gap. My goal is to spark and accelerate a conversation within public health and beyond about what our role is in closing the gap between impending risk and potential for a healthier, more equitable, and more sustainable world. I begin by proposing 5 premises that constitute a foundation for forging a public health agenda for the 2020s. And in the discussion period, I hope some of you will support or challenge these premises, and that together we can consider their implications for public health practice, research, and activism. So I'm going to talk a little bit about each of these premises. So the first, business as usual is not working. Mainstream approaches to public health, categorical programs for each separate health problem, a focus on individual responsibility and behavior change, roots in reductionist biomedical models, and efforts to cooperate and partner with market actors are not working. Our public health problems are getting worse, not better. The number and magnitude of risks are increasing, and the capacity of threats like the COVID pandemic and climate change to overwhelm our current public health approaches, I think, are readily apparent. And in the face of what seems like overwhelming evidence that current approaches are not working to improve population health and reduce health inequities, too many of us continue to believe that we can just keep doing what we're doing and hope for the best. As a profession that prides itself on being driven by evidence, we need to insist that we reject business as usual as a viable strategy. Premise 2, our current global economic and political system is the fundamental cause of the health apocalypses of the recent past. No, it's not the only cause, nor is it a conspiracy by an evil cabal to sicken and kill the world's population. But in my view, a growing body of evidence and public health and social science scholarship suggest that 21st century capitalism is what social epidemiologists call the cause of the causes. It is driving the escalating climate crisis, the rapid global spread of COVID-19, the growing burden of chronic diseases, and the rise of income and wealth inequality, itself a driver of health inequities. In At What Cost, I show how some of the essential features of 21st century capitalism listed here, corporate managed globalization, financialization, deregulation, austerity, corporate control of science and technology, have contributed to the most serious health and environmental problems facing the world today. And because I believe that the job of public health researchers is to link problems of health and disease to people's everyday problems, I also propose that these same features of the political and economic system that define 21st century capitalism undermine what I call the 6 pillars of health. These include the food we eat, our education, our healthcare system, our work arrangements, how we organize transport, and how we connect to other people. There are other pillars as well. These are the 6 I chose to examine in my book because I think there's a robust body of evidence to document this. These pillars of health shape our living conditions, our opportunities for health, and our patterns of inequity. In short, how and when we live and die. A critical imperative of public health is to identify and modify the social and economic characteristics of 21st century capitalism that have made it so toxic to human and planetary health. Identifying 21st century capitalism as a fundamental cause of ill health and health inequities brings both difficulties and opportunities. The difficulties, talking about capitalism to mainstream America, has until recently been as popular as poison ivy. And the public health community includes those who embrace, detest, and are indifferent to capitalism, hardly a foundation for consensus. And I'll have more to say about that later. But by identifying a common cause of the major health problems facing the nation and the world, we create the opportunity for forging a shared common agenda, one that breaks out of the silos that so hamper our effectiveness. And deciding that a political and economic system that brings pain, hardship, anxiety, and early death to so many people here in the United States and around the world, we open the door to creating the broad alliances that have in the past won public health advances, such as the abolition of child labor, the establishment of universal education, and the regulation of food and drugs. Moreover, the premise that the current political and economic system is the driver of ill health opens the door to the application of powerful conceptual approaches, system science and systems thinking, syndemic theory, and a more focused and action-oriented application of the social determinants of health. Some in public health and progressive movements argue that identifying modern capitalism as the fundamental cause of our health problems ignores the influence of racism, sexism, and other systems of oppression. I certainly recognize the vital importance of addressing these pathogenic stratification systems. But in my view, today's world racism and capitalism are interlocked systems. And as the quote shows, and as Ibram X. Kendi has expressed it, the two systems of oppression are conjoined twins, and that the origins of racism cannot be separated from the origins of capitalism, and the life of capitalism cannot be separated from the life of racism. Both Martin Luther King and Malcolm X and many others have expressed similar ideas about the links between these two systems. And as we've learned from Black feminists, such as Kimberly Crenshaw, Paula Marshall, and many others, these systems also intersect with sexism, making the experiences and health challenges of Black and Latino women different from Black and Latino men. The challenges for health researchers is to understand how these intersectional influences shaped the lived experience of these different populations in our society and the opportunities for mobilizing resistance. Another great insight of the feminist movement of the 1970s, that the personal is political and that the political is personal, provides both health professionals and activists with tools to explain the connections between our political and economic system and the daily experiences of dis-ease. Another role for public health professionals and advocates is to put new ideas on the policy table. Fair taxes support healthier communities. Public benefits like paid sick leave enable us to better care for our families. And restricting Facebook and other social media companies from invading and capturing our children's minds and lives so that they can sell more ads are examples of recent public health campaigns. These are designed to publicize and gather support for policies that turn these ideas into reality. Premise 3, the driving force for the changes that will enable our nation and world to overcome major threats to health will be the social movements that force governments and businesses to modify business as usual. The history of public health shows that when reformers, people-oriented political officials, and social movements join forces, they can sometimes overcome the opposition of business and wealthy elites who benefit from the status quo. As I said, the regulation of food and drugs, the end of child labor, the environmental protections enacted in the 1960s and early 70s, and the expanded safety net enacted in response to the COVID pandemic are illustrations of this power. Our test is to apply the relevant lessons from these victories to our era. At least in part, the goal is not to break the traditions that led to earlier public health successes, but to return to these approaches after they have been weakened by market fundamentalism and the ideology of individual responsibility. Which brings me to premise 4. The evidence we need to transform public health practice is not hidden in obscure medical journals, arcane leftist theorizing, or the randomized clinical trials we will never have the funding to support. Rather, it's all around us. Somewhere in this city, in this nation, and in this world, thousands of people and organizations are forging creative and promising solutions to the public health problems that confront us. Somewhere, activists are successfully mobilizing communities to confront the unhealthy status quo. Somewhere, public health officials are implementing policies to restrict predatory marketing and reverse price increases in essential medicines. And somewhere, researchers are creating new understanding of the specific pathways by which commercial actors for profit organizations are harming health or distorting science, and identifying strategies for disrupting or blocking these harmful paths. Practice-based evidence has the potential to, sorry, I skipped ahead here. Practice-based evidence has the potential to guide public health policy, practice, and research. Of course, we also need to continue to create new evidence. But in my view, the solutions to the public health apocalypses now confronting us will come less from new scientific discoveries and more from synthesizing what we do know and applying it to the hurly-burly economic and political world we live in. And systematic research on what does and does not work to overcome entrenched interests, to break out of siloed or biomedical thinking, and to build bridges from incremental to transformative changes. An implication of this premise is we need to rethink and expand how we train public health students to design and conduct research that will truly make a difference. Once again, business as usual approaches here in our schools of public health will not do the job. Premise 5, the last one, maybe the last important, maybe the most important. A vital role for public health is to insist that there are alternatives to our current political and economic system. In my experience in research, practice, and advocacy, I've encountered no greater obstacle to meaningful public health advances than the belief, as Maggie Thatcher once said, there is no alternative. In my teaching, community work, and advocacy, I meet many more people who agree with our assessment that current approaches are not working, but have lost hope that better options are achievable, and that those who think that we live in the best of all worlds than those who think that. And why is this? First, I think that the pace of modern life, especially in our capitalist system, overwhelms people's capacity to imagine change. If we're worried about our housing, our healthcare, our children's future, our old age, our employment, our diet, our education, much less the state of the nation's politics, it's hard to take a step back to consider alternative arrangements, and easy to feel first overwhelmed and then incapacitated. The pervasive insecurity and anxiety that characterizes 21st century capitalism is itself an obstacle to imagining a better future. Second, for many years, corporate leaders and business organizations have sponsored robust public health relations campaigns to persuade us that the world we have is as good as it gets, that any alternative to the current system would inevitably be worse than what we have, and that protest, however well motivated, is futile in today's world. These all too successful campaigns have led even many committed to social justice, young people, people of color, women, and other activists to give up voting, going to demonstrations, organizing, and educating their communities, all activities they sometimes deem to be pointless. In truth, via social media, mass media, and our peers who are paid or unpaid social influencers, we're bombarded with messages that we are lucky to have all the choices corporate America offers, and this is as good as it gets. And third, another reason why it's hard to imagine change, in reality, it has gotten harder to bring about meaningful change. The wealth and power of the world's biggest corporations, their influence on our elected officials, and their control of an ever larger share of the world's media make it difficult for alternative views to be heard. At the same time, many of the institutions that used to offer countervailing power, such as families and kinship networks and labor unions, faith groups and communities, have lost power and the ability to put real alternatives on the policy table. So the belief that there is no alternative is a powerful obstacle to public health and social improvement. And for that reason, developing public health strategies, methods, and a practice that challenges this disempowering belief are vital. And I'll say more about that soon. I've outlined 5 premises that I believe are the foundation of a new public health practice that suggests an alternative to the business as usual approach. I recognize that these premises leave us facing some daunting prospects. In the last part of this talk, I want to tell you why I remain optimistic. My goal is to relieve the depression I may have triggered in you all with this grim analysis, and to explain why I think public health professionals must be both Cassandras, speakers of true prophecies, and to overcome the disbelief that Cassandra evoked, we must also be visionaries, promoters of hope, optimism, and the possibility of better, happier, and healthier lives. So here's why I'm optimistic. First, I think we have a moment where many people and organizations are dissatisfied with the status quo, a time when the COVID pandemic, the climate crisis, and other public health apocalypses make it increasingly apparent that business as usual is not working. I'm also optimistic that health and well-being have the potential to bring people together across the many divides that now characterize our society: race, political beliefs, urban, rural, and others. Despite the polarization, almost everyone wants good health for themselves, their children, and those they care about. Large majorities support public health measures that protect their health, such as stronger environmental regulation, better access to healthy, affordable food, safe housing, safe work, decent health care, and access to essential medicines. Public health professionals and activists can contribute to converting this support into actionable legislation, policy recommendations, and budget allocations. Another opportunity is to continue our efforts to denormalize business practices such as predatory marketing of unhealthy products to vulnerable populations, unaffordable prices for insulin and cancer medications, and the tax evasion routinely practiced by the ultra-wealthy and corporations, a practice that derives governments of needed resources and accelerates the inequality that sickens us. I'm also optimistic, with a high degree of caution, that we have a potential for renewed commitments and support for dismantling systemic racism. The mobilizations stirred by Black Lives Matter, more people on the street demonstrating than ever before in US history, debates in city halls, state legislatures, police departments, and school boards, and the intense discussions within academia, I think, are cause for hope. Similarly, the concept of solidarity, of the solidarity benefit, proposed by Heather McGhee in her book, The Sum of Us, provides a powerful frame for the gains that come when poor and working class, white, Blacks, and other people of color join forces to demand improved living and working conditions and a fair distribution of national wealth. Yes, I acknowledge centuries of the dismal history of racism in our country, but change is inevitable, and we have an opportunity to shape that change in more positive ways than I have seen since the height of the civil rights movement more than 50 years ago. Corporations are vulnerable. Yet another reason I believe the time is right for initiating transformative changes in the corporations and market fundamentalism, and to exploit their new vulnerability. ExxonMobil, Altria, and Blackstone, to name a few, still engage in practices that harm health, but they are also desperate to improve their image, protect themselves from stronger regulation, and prevent the multi-trillion-dollar disinvestment campaigns that have hit the tobacco, fossil fuel, and firearms industry. A 2019 national poll found that 1/3 of Americans had a negative view of capitalism, with a proportion of young people who are skeptical even higher. Another indicator of the potential for a more robust national conversation on what kind of society Americans want is a look at the issues now on the national political agenda, as manifested both by media coverage and debates in local, state, and national governments. Democracy is on the table. Fair taxation is on the table. Reconsidering the role of government in ensuring a decent life is on the table, and protecting the human and other lives from extinction is also on the table. Compared to 10 or 20 years ago, public health workers have new opportunities for engaging ordinary Americans in discussing and acting on these issues. I'll end by proposing some specific actions we can take to realize the improved prospects for forging a public health agenda that is an alternative to business as usual. First, as researchers, we need to expand and strengthen our search for what works to take on the most fundamental drivers of ill health and make more meaningful improvements in health and shrinking health inequities. Public health makes significant contributions when it takes practical steps, like John Snow, removal of the handle from the Broad Street water pump in London in 1854 to slow the spread of cholera. Rudolf Virchow's advocacy for new social safety nets to protect against infectious diseases in 19th century Germany, or the recommendations that researchers and activists made for removing lead from the drinking water in Washington, D.C., Flint, Michigan, and elsewhere. Public health and social science researchers also contribute when they illuminate the deeper forces that drive health. Matthew Desmond's work on eviction, the work of your own Center on Healthy Work, on policies, programs, and practices that can remove barriers to improved health of low-wage workers and precarious workers, and Michelle Alexander's work on the impact of mass incarceration are examples. Second, we need to talk about capitalism. Understandably, the shadows of the Cold War and McCarthyism, the failure of the Soviet Union, and the ideological hegemony of corporate leaders has made many, including those in public health, reluctant to let the C word cross our lips. But for health researchers, especially those of us influenced by social determinants of health perspectives, to be unwilling to name the system that has become the fundamental driver of patterns of health and disease is like physicians being afraid to use the words human body. What we do not need is to agree on a common goal for an alternative to the current regime, nor to declare allegiance to any particular brand of capitalism or socialism. Nor should we make the mistake of assuming that capitalism is a single homogeneous system. In fact, a quick look around the world shows many varieties of capitalism across the world, a variability that should entice researchers to study the differences in health outcomes across these variations. What we do need is to chart the pathways by which the changing economic and political manifestations of 21st century capitalism influence health and identify the opportunities for upstream and downstream incremental and transformative changes that will prevent or mitigate harmful consequences. In discussing the role of capitalism in health and disease, public health workers need to connect the changing dynamics of the market system with the lived experience of ordinary people by helping our patients, consumers, workers, parents, and activists understand the links between the personal and political, the very tasks that Paulo Freire, the Brazilian educator, wrote about 60 years ago. We can assist the millions of people harmed by the current regime to take action to change it. A third recommendation is that we ground our public health and political practice in the real world efforts of others looking to bring about change. As the Spanish poet Antonio Machado wrote in 1913, "Traveler, there is no road. The road is made as you go." There is no map to that other, healthier, more equitable world. By using historical insights, practice-based research, participatory and action research, we can light up the paths to more effective policies and change strategies. A related imperative is to use our voices, power, and intellectual capital to defend truth and science. Uncontested assaults on science, failure to respond to false and unjustified personal attacks on scientists or health professionals, or simply silence in the face of corporate or partisan disinformation campaign leaves our credibility in question. And it also makes it harder to stand up to the next loony or dangerous effort and to denormalize the idea that evidence can be fabricated to advance any goal. And finally, as I've already suggested, we can insist that another world is possible. Those of us working in public health today didn't ask to be charged with writing the next chapter in our field's history. But here we are, confronted with a cascade of public health apocalypses and an extraordinary set of opportunities to overcome them. What a scary time to be a public health worker, and what a wonderful time to be a public health worker. Thank you very much.
Thank you, Nick, for just an incredible tour de force presentation. And I'm going to toggle a little bit between our remote attendees and those of you here in person in terms of what Nick said at the outset. Questions, challenges to premises, it's all on the table. So I'll start with anybody in the room who'd like to kick us off with a question or comment. Eve.
I think one area where I'd like more elaboration is thinking about the possibilities for bottom-up change. A lot of our theories of change tend to be driven, by the ideas of changing policy and changing legislation. But even, in doing that, you still have to build for it, and that requires more bottom-up thinking. Margaret Mead said, as is well known, never think that a small group of committed citizens can't change the world. In fact, it's the only thing that ever does, and there's a lot of systemic wisdom, to me in that statement. dialogue and deliberation.
Let me,
Spaces where potential. So, yeah, I want to use that more on, on bottom-up pathways to the future.
and I will not try to do justice to that elaborated comment, but for those remotely who might not have been able to pick it up, Eve, my colleague Eve was asking Nick to comment on bottom-up strategies for change and how those can be a source for transformation as well, and perhaps are fundamentally important for those upstream changes to occur.
I very much agree that community level mobilization of the populations most hurt by the current system are the motor force that will change the system. I also do believe that integrating bottom-up and top-down strategies is vitally important. And I think you were suggesting this. One of our roles as public health workers, as well as those of us who are also activists, is to create spaces where people working at those two levels can exchange ideas, and also to create safe spaces at the bottom-up level where people working on different issues, on food and labor and women's health and dismantling racism, can talk to each other. We spend so much time either duplicating each other's work or actually fighting with each other. And there are many important arguments that we have to have, but we need to find safe spaces to have those arguments so that we can keep our energy focused on the people who are making this world that's, in my view, making us sick. So thank you for that comment.
Thank you, Nick. I'm going to share one from the chat, and I'm going to try to also synthesize it down to a somewhat briefer question. But this person is interested in having you comment on kind of the revisions, fundamental CDC revisions to 170 plus years of public health, and mentions this including but not limited to privatizing mass vaccination and militarizing it through FEMA, who never did mass vaccination before, and for the first time directly giving vaccine to CVS and Walgreens, bypassing local health department along with the majority of state and local health departments in the US, privatizing testing, contact tracing, vaccination, instead of using billions in federal funding to rebuild their public health departments.
So I think to take a big step back from the particulars of that question, it is consequences of several decades of what some people call neoliberalism, privatization, deregulation, an emphasis on individual responsibility that left governments incapable of responding to the COVID pandemic and the climate emergency and the other public health apocalypses. And I think because of the great power of corporations and wealthy elites, even the emergency responses of the COVID pandemic were subject to those same forces. I think there probably is a half empty and a half full story there. I think some pieces of the broad pandemic relief, not limited to the public health, are steps in the right direction of a reassumption of public responsibility for safety net programs around food and housing and labor and unemployment. And we should both celebrate those, but most importantly, push to have them expanded and institutionalized. On the public health level, again, answering a little more broadly than the question, I think only government has the mandate and the authority and the resources to protect public health. And if the government turns over responsibility to the private sector, they will always look for ways that will enable them to make a profit. And in some possible cases, maybe it's possible to make a profit and also protect public health. But in most cases, those are conflicting imperatives. And so by turning over responsibility for protecting public health to the private sector, you lose the opportunity for assuring both that it achieves its goals of promoting public health, and most importantly, you miss the opportunity to ensure that the progress also leads to reductions in health inequities, because within the market system, those who are better resourced always do better.
Thanks, Nick. Yeah, in the back there, please.
How's it going? I'm a first year MPH HPA student. Last 8 years of my life, I've spent working in the public sector. I've done social work. I've done, which was primarily aimed at reducing barriers to care associated with people getting low viral loads. In order to achieve an undefected status, worked as a court clerk in the New York State Unified Court System. And as I progress, it's increasingly frustrating to realize how much of the system is broken. I understand that this is, aiming at having a conversation around capitalism, and I understand that it's incremental steps towards a better future. However, my question is that as someone who is trying to break into this arena, it's coming from where I am, doing a work in progress and seeing it firsthand. Now coming into an academic setting and reading about it, it just, the frustration doesn't seem to be going away, or the incremental steps don't seem to be actually like visible or tangible. So it's kind of upsetting in a sense, of course, but at the same time, it's like you want to do better. So I guess what would you say to that as if not get frustrated now and keep going with it? Because I know a lot of people in this room have been doing this for 10, 20, 30 years. And at that same time, it's like over the course of professional lifetimes, you probably have seen change. But in my short experience, I don't want to sound jaded or anything, but it's like, but it's
No, thank you. And I'll again, just a very brief recap. If those online were not able to fully hear your comments, is from one of our master's students with a lot of experience coming into our program. This is often the case. And seeing the challenges in that regard for creating change, and then kind of hearing about it in the classroom as well. And I guess, as sometimes said, how to keep your dauber up and keep up the good fight when it seems like it's perhaps, putting words in your mouth, but feels like it's a stagnant situation without progress to be had.
So first of all, welcome to public health academia, and welcome to the frustration that we live with. A different kind of, because I've also worked in those frontline positions in New York, and that's another kind of frustration. I have a few possible answers. One recommendation is that I've followed is to get old, and that when you've been doing this for 40 or 50 years, what you see is that some of the things that look impossible when you're in the midst of it really change over time. So I've, in my lifetime, I've seen the discrediting, not yet the dismantling of mass incarceration as a strategy to improve public safety. I've seen questioning of the war on drugs and a beginning of change in that perspective, including what city governments are doing. We've certainly seen, the dramatic changes in the law and public perception of gay, lesbian, and other people of various genders. And those around, the legalization of gay marriage, a year before it happened, everyone would have said, this is not going to happen in my lifetime. And it happened because there were social movements. It happened because there was a concerted effort to change things, and it took a lot of time. And it also happened because the activists worked really hard on coming up with frames that would win their goals. And the frame that everyone should be able to love the person they chose to, that was a very powerful frame. To switch to a totally different environment in the tobacco control movement, which also took decades to be successful. It was the frame that people have the right to breathe clean air that surpassed the claim that the tobacco industry promoted, that people have the right to smoke. So I think as you're around for a little longer, and I hope it doesn't take too long, you'll see some of those victories from things you worked on, back in your days in the trenches, or that you're working on here in public health. And I think the question we ask to not be simply waiting around for change is to ask, what can we do today? What can we do today, both to advance the incremental changes and to put ideas on the table for transformative changes. And I hope that what you'll learn in your public health training is some of the skills that will help you to do that. And your experience, including the experience of frustration, I think will be very helpful in that too. I hope that speaks to your question.
Yeah, and I will add, do not hesitate to, and please do challenge all of us in the roles of being instructors in the school to not, support transformative thinking, and no matter how challenging it might seem to make come to reality. I'm going to read a question from Susan Kaplan. Dr. Freudenberg, wonderful talk. I'm wondering if you have any thoughts about ways to reduce silos. For example, the CDC suggested people drive to work alone to reduce the risk of COVID transmission, which would of course increase air pollution. Public health and environment are often addressed separately, and as are many issues that affect health, as you discussed. So she appreciates your talk and very much interested though in what your ideas are for breaking down silos and this effort to create a new approach.
Sure, really good question, Susan, thank you. I can give some practical answers. I've been part of the City University of New York Urban Food Policy Institute for the last several years. And in our assessment of what would it take to advance food justice in New York City, our analysis was that people working in the different siloed sectors of the food movement had to start working together. And so we created an institute and looked to attract faculty and students and staff who were interested in food insecurity, in diet-related disease, in food labor, in the impact of our food system on the environmental system, in food as a tool for economic and community development. And by bringing together people who worked in those different areas, we were able to begin to see some of the synergies and also some of the conflicts that we needed to talk out. And we also very much believe in creating a place. And so we have monthly forums where, in part thanks to Zoom, we now have 100, 150 people who are active in food policy in New York who come together every month to discuss food issues, that kind of learning community of people working across issues. And I think we can do those kind of creating spaces both at the horizontal level, people working in a community on housing and food and labor need to come together, and people working at the city, state, and federal level. Those are modest starting points for beginning to break down siloization.
Thank you. Thank you. Let me see if there's another question from the audience here. Lorraine.
You want me to come up and say it?
Yeah, it'd be wonderful, Lorraine. Thank you. Put you on the spot. That's
No,
great.
I'll just get closer to the mic. I have two questions that I think are related. One is a follow-up from my student's question. So I teach the determinants of population health class, where we've really structured the class to address, I think, the first three of your, maybe four of your premises. And by the end of the semester, I have 60, and this semester I have 100 students that are super depressed that they came into public health. And so it's like, I don't know how to get to that next step of like, what are the solutions? What do we do as public health practitioners? And so some of what you talked about today, I think, is helpful in terms of how we act as practitioners, but I want to ask about how we act as professors and teachers in this area. Like, how does our curriculum need to advance to give our students those skills to address the final two premises? And that's, so the follow-up to that though is, how do we change the research area? So you also talked about the need for participatory and action research, which is not the same. I mean, it's not hypothesis testing. We don't have control groups. We don't have the ability to conduct that kind of research in 3 years. So how do we change the sort of funding structure that academia is operating in to allow for that kind of evidence base?
Sure, those are big, important
Yeah, I was gonna say
questions.
not one, but two challenging questions, Nick.
So I'll
But
start
they're
with teaching.
related.
That's okay.
I think in higher education in general, and I know at City University, we're talking a lot about experiential education. You know, that people early on get out in the field, meet with people who are working in the front lines, and I think we need to do more of that. I think the divide between theory and practice is a disempowering divide, and the sooner and the earlier we can help students to connect that by being out there, and then, you know, a la Freire, critically analyzing those different perspectives. I also think, and this is probably less true for your school and our school, for public universities, we need to ask, who are we accepting into schools of public health? And schools of public health have made some progress in recruiting students from the communities most in need of public health services. But the public health student body is still whiter and more middle class than the American people. And we need to think about, if our job is to train the people who will fix, who's best able to do that. I have a doctoral student I'm working with looking at the admissions policies and practices of schools of public health across the country to see actually what are they doing and how is it working to change the demographic composition of their students to better ensure that all communities' needs are met. And people who have the lived experience in a community experiencing a problem will be able to conceptualize both training students and doing research in a different way. And we'll have had experiences both of public health oppression, but also of working to change that I think will really benefit. And I know where, you know, half our students at the CUNY School of Public Health are students of color. Many come from other countries, and there's just so much we learn from each other by having that diversity of experience in the classroom. On research, my dean, Ivan El Mohandes, and I and some colleagues wrote an article a few years ago about the responsibility of public schools of public health. And I know all schools of public health are under pressure to raise revenue, but I think public schools that have whatever level of support we do from the public have the capacity to go beyond the revenue generating formulas of the private schools of public health, which is so dependent on NIH funding. And we ought to leverage that power we have of that other level of public support to rethink the research we do. And again, I had the opportunity to talk for a few minutes to your dean this morning. I know your School of Public Health is working closely with the city and the state. I think all our schools of public health, that is a body of research, and we need to be asking the government agencies that come from the government entities that fund us, right, that pay, you know, our bring in our revenues, to say, what do they need to know and how do we do that? And then we need to find ways of engaging with communities to ask research questions. And I understand that's not a quick change, but I think the move to the biomedical model in public health has been of a few decades. It was not always that way, and it was the decisions of university leaders that were, to my mind, essentially business decisions, corporate decisions, and that isn't how the future of public health should be faced. So I think we need to look for different models. That will be a long, hard fight.
Thank you, Nick. And it kind of ties it all together, taking the corporate model back to our own home environment, and good food for thought. And this, again, you know, I'm sure I'm speaking for everyone who's been a part of your session today, just greatly enlightened and stimulated, or maybe a little depression too, but the two emotions can exist together. Just hope everybody will join me in thanking you one more time. thank you to the remote attendees as well. And also for those of you who were here in person, we will have a recording of this talk available as well, which we let people know online. Thank you.